it mine. I will give you the history now.
Okay. Shall I ask for control?
Okay, no problem. You can ask. 35 years old female with 2 days of vague central abdominal pain.
35, sorry? 35.
35.
35,
Yeah.
okay. So I'm presented with CT abdomen with contrast, arterial phase of a 30-year-old female patient. I don't know, it's not scrolling.
Scrolling down.
Yes, start scrolling now, yeah. Of a 30-year-old female patient presented with vague abdominal pain. I'll scroll from the first to the last cut and then start giving my comment. First, I'm checking the solid organs as well as the bowel with the vessels. The vessels, the bladder, the uterus. So, I'm starting to search for the cause of this vague abdominal pain.
Okay, you
So,
didn't find the
yes,
interest
I
radiology
didn't
on the
find a
radiology.
major
You have to go
abnormality.
systematic, okay?
Yeah, okay. So, I will start searching for the causes of the abdominal pain. I can't see any like gallstones. The pancreas is within normal size. Both kidneys are normally enhancing. I can't see any splenic or hepatic focal lesions.
Okay, the
The bowel
patient
is not
two,
dilated.
2 days of vague abdominal pain. 2 days, which
2 days,
means
not acute, not. Mm,
not 2 days, not acute,
I mean, not
not
emergency,
chronic,
something like that.
not chronic.
Not chronic. Okay,
So search for causes of acute abdominal pain.
okay.
Okay, concentrate
Can
on
I
the bowel.
can I ask? Yes, on the bowel?
Yes. What causes of acute abdominal pain
So,
in?
uh, this bowel loop
Yes.
appears really as if it contained like a fat dynasty or
Okay.
uh,
Can you
I'm
describe it to me?
suspecting I'm
Concentrate on.
suspecting it may be like a
Wait, wait.
target sign. Yes, okay.
Yes.
Yes.
How? Yeah, try to, if you found the abnormality, try to describe it.
Okay. Okay.
Which loop?
So,
Like this. Yeah, don't go
okay.
for diagnosis. I'm
Diagnosis, yes, okay.
Even if you know the diagnosis, you have to tell the
Okay.
examiner your
Okay.
approach. Okay.
Okay. So, so I can see like two bowel loops uh, within each other with
Okay.
hyperdense hyperdense peripherally and hypodense internally, giving the appearance of pseudokidney or target sign.
Okay.
Probably this is uh, ileal intussusception. Uh,
Ileal.
yes, ileal. Sorry.
Okay.
But I will confirm again in the coronal
Okay.
reformatted images.
Wait, wait. Okay, this is the corona.
Okay. Sorry, the scrolling is a little bit skipping.
Wait.
Okay.
Scroll slowly and concentrate on the area of interest.
Okay.
Okay. You found the pathology, yes.
Hmm.
What's the pathology?
So, the pathology, as we said in the axial,
And
this It's not
What is the
stopping when
pathology?
it is not stopping when I want to stop.
Leave the mouse. Leave the
Sorry.
mouse. Leave the
Okay.
mouse. Leave the mouse.
It is not stopping where I want to stop. Okay.
Okay,
So
wait.
yes, yes,
Okay,
this is
we
where I
found the
want to stop.
pathology. Yes, okay, we found the pathology.
Yeah.
What is the pathology?
So it's two bowel loop
Intercep-
interception.
Interception.
Yes, interception.
What is the cause? What is the most common
S-
causes for interception in adult patient?
So adult patient, it can be idiopathic, but can also have a lead point of a mass.
Most common in adult
So
patient idiopathic
no, most commonly there is a lead point.
should be lead point. Okay,
Lead point. So with
like
this fat density, I'm suspecting maybe a lipoma to be
okay.
the cause of this interception due to this
What
fat
other
density.
causes?
But so maybe
What
also
other
like
causes?
yes, maybe carcinoid, maybe malignancy, but regarding the age of the patient, being like a young patient, uh, my first possibility will be like benign tumors rather than malignant tumors, especially in the absence of any pathological lymph nodes.
Okay. Will the lipoma
Uh,
will come elongated like this?
this is the point that I'm thinking about.
Okay, you are
Uh,
thinking, but you didn't tell me.
yeah, yes, I didn't think. I was thinking why the lipoma is like oblong and elongated like this shape.
Okay. Anything
Uh,
else come in your mind as of this shape?
I'm thinking of Meckel's. No, I think it's not the thing. Mm.
Why not?
Why not Meckel's diverticulum? Because it's like mostly it's like it's more like near the appendix, not
Mechels is near a... Okay, what is the rule of two?
yes.
The Mechels diverticulum.
So it's 2 centimeter long, 2 centimeter from the ileocecal valve. I'm not sure.
2 centimeter?
uh,
2
yes,
centimeter from ileocecal valve?
not sure.
Or
Mm.
2 feet? How much? How much 2 feet?
How much to feet in centimeter? I don't
Yes. Okay. Okay, how will you manage
know.
this case?
So
What is the
I'll
complication of
urgently
inter...
ischemia, of
Okay.
these bowel loops. But I can't see any sign of like decreased enhancement of the bowel of this bowel wall.
Okay. So
Uh,
no need for emergency, yes?
no, it's an emergency because it may develop later on.
Okay. So we will urgent...
So yes, we'll urgently convey the finding, pick up the phone and urgently convey the finding to the referring clinician, and the finding will be discussed by the surgical team. Uh, I think in adults, it's usually like surgical reduction rather than
If it is
pneumatic
Mechel,
reduction,
they,
not
they
reduction is
will...
more in pediatric group.
Okay, thank you. I helped you so much in this case. I don't know why you didn't get my help.
Okay.
Okay. By the way, in the exam,
Mm.
you will go here, and the examiner will not give you time to do all this. By the way,
Okay. Mm.
if you scroll once and go again and you didn't reach the area of interest, he will ask you, look at this region.
Mm.
Okay? I told you again, the patient is 45, complaining of 2 days vague abdominal pain. Okay? You may not
Yeah.
listen good to the history.
The
And
problem
then,
that I suspect the abnormality in the first scroll, but I thought I didn't get that is maybe interception.
okay, how will the examiner know that you got the abnormality?
uh,
This we are talking about. If you saw anything, tell the examiner, I am suspicious about this region.
mm,
Okay? So if it is abnormality, what's the abnormality? Okay, what should be like, what is the possibility? He will take you to
mm,
the case. But if you
mm,
go up and down, he will not. Yani, then he will cut marks from you because you didn't tell him what are you seeing. Okay.
Okay.
So I'm looking, okay, look, he will not let you, liver is good. No, I will ignore. Go to the bowel. But
Mm,
if he told you go to the bowel, okay, he will cut from you at least 2 marks from 4
mm,
in observation. If you go for the bowel and you go for scroll and you didn't detect the abnormality, he will cut the next two. So he will cut the 4 marks for observation. Okay.
mm,
So try, if you found abnormality, tell the examiner, I'm suspicious about this region, I'll concentrate on it. If it is abnormality, he will go with you. If it is not, he will tell you, ignore about that, no abnormality here, or like this, okay? Bowel is normal. So it detects the abnormality, describe it very well, okay? There is double wall sign here, looks like target sign, central hypodensity, likely representing fat density. Okay, so I'm suspicious about fatty lesion. It is again it's to be lipoma. It is likely to be
mm.
interceptum first, interception, but
Yes.
against lipoma to be because this patient is an adult patient, so I am thinking in 90% of cases there should be lead point,
Mm,
but this fatty lesion, but it's against to be lipoma.
mm.
So I have to look for the coronal images. Coronal images, I can see there is two bowel loops. So you see this bowel loop, go
Yes.
here and here. It is connected to
Mm,
a small bowel. Okay, this one.
yes.
So it is a case of interception with fat content. It is
Yes.
an emergency. You didn't go for the diagnosis, but you tell
No.
him, if I
Mm,
found this abnormality, I will go for emergency to refer the patient, so I am safe.
mm,
For this patient, if you refer this patient of interception to emergency for the surgery, and they relieved the interception and removed the
mm.
lesion, and it was the Meckel's diverticulum. Okay,
Okay.
if you didn't tell them it is Meckel's, or you told them it is Meckel,
Mm,
it will not differ,
okay.
but the management
Mm,
is safe for the patient. Okay,
mm.
because we
And
are dealing with emergency case. Okay, so
so
I
what was
will.
the final diagnosis of
This is Meckel's
Meckel's diverticulum?
with interception. Okay,
So it's my
if you
first
look,
time to see Meckel's with fat on this one. Mm, good.
this is
Mm.
omental fat.
Oh, mental fat. Mm,
Omental fat. He takes the momentum and go
mm,
invaginated within the bowel. By
mm.
the way, the appendix
Okay.
here is normal here.
Yes.
So if you
Mm,
Meckel's may come here. By the way, okay.
mm,
Next thing, what's happened now
mm,
in the exam? Okay, you reached Meckel's diverticulum. He will ask you questions
mm.
about Meckel's. This is called radiological knowledge.
Yes.
This is one of the 5 parts they will evaluate you. Okay,
Mm,
you have if rule of two. You have to give him rule of two. Okay, if you told him I don't know, so you don't know the complication of Meckel's.
mm.
Complication of the Meckel's, first, hemorrhage. What is the cause of hemorrhage in Meckel's diverticulum?
If it contains gastric mucosa.
Yes,
Yes.
gastric mucus, so ulceration
Mm,
and hemorrhage.
mm,
Okay. What other complication? Small bowel obstruction from
mm,
other inflammation, acute inflammation, maybe acute Meckel's diverticulitis,
mm.
one of the complication. So give the examiner space to ask you question. Okay.
Okay.
To take
Okay.
more marks because you will be evaluated on this clinical 4 marks on the radiological knowledge.
Knowledge. Mm,
Yes. So it is very important nowadays to build up your radiological knowledge. Not like before. Before, okay, Michael's interception, next case. Okay, you
mm.
reach the diagnosis, what's the management, refer to the surgeon, okay, no problem. Now, no.
Okay.
You
Mm,
have only 12 cases. Every case, there is a structured question for every case for all the candidates.
okay.
Okay, if you answer the question, you will take the whole marks. If you didn't answer, they will cut marks easily. Okay.
Okay. Thank
So
you.
for learning a point for rule of two in Meckel's diverticulum, 2% in population, presentation at 2 years of the age, 2-inch long, about 5 centimeter, 2 feet from the electrical valve. Like this case.
No.
2 feet means 60 centimeter. Okay? So it is away from the electrical valve. What is the difference between Meckel's and appendix?
Difference regarding which point?
Tell
The
me.
symptoms? You
Anatomically,
mean the symptoms?
anatomically, the Meckel's will arise from the ileum, but the appendix will arise from the cecum. Okay, like this. Okay, and also appendix contain bowel mucosa. This Meckel's contain gastric mucosa or pancreatic mucosa, like this. Okay.
Okay.
So,
Thank you.
welcome. Thank you. Candidate 10.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. Candidate 10.
Yes, sir.
I think the candidate has the remote control and stop sharing. Okay, candidate 10. Your case is 10 years old female patient, recent cough, and she is complaining of bone pain.
Yes, sir.
Go ahead.
This is exit chest frontal projection of a 10-year-old patient with a history of bone pain. Here I can see there is a lung fields appears normal, no evidence of any pleural effusion, pneumothorax is seen. Heart cells appear normal. The ribs appears normal. Clavicle appears normal.
Candidate 10. I couldn't hear you, candidate 10. Candidate 10. Can you hear me, other candidates?
Yes, Dr. Munir.
Yes, we can.
Okay. Okay, we will shift for next candidate till
Yes, Doctor, I'm here.
You are 11, yes?
Candidate 11, yes.
Yes, okay.
Okay.
Candidate 11, your case.
Okay.
70 years old male patient with 2-week history of progressive leg pain and difficulty walking.
Great. So this is sagittal T2 weighted images of the cervical and upper thoracic spine for a 70-year-old patient who presented with lower limb weakness and pain. I
For
can.
the remote control?
Yes, sure.
Can you?
Yeah. Okay. Requested.
Okay. Approved. Okay, go ahead.
Right. So this is the sagittal T2 weighted images. I will take a few seconds, please, to scroll through the stack and then convey my findings. Okay, so upon the first scroll, I can see that there are multiple hyperintense T2 weighted lesions seen within the cervical and thoracic vertebrae. And there are multiple decreased vertebral body heights, particularly affecting 2, 3, 4, 5, 6, 7, 2, 3.
Okay, no problem.
T7,
No,
yeah,
grab out the
T7
number.
vertebra with a Schmor's nodule in the inferior endoplate. There is also some increase in the kyphotic curvature of the cervical, of the thoracic spine. The cord appears indented at the mid-cervical spine, and there are a few subtle hyperintensity to weighted foci within the cord. There is also some indentation upon the anterior subarachnoid space in the mid-cervical spine.
Anything else about these degenerative changes?
Yes, the bone marrow signal appears inhomogeneous, which might be acceptable for the patient age since it can happen with osteoporosis. The craniocervical junction and what's seen of the posterior fossa appear unremarkable.
Okay, I will give you some more history.
Yep.
Patient 2 weeks history of progressive leg pain, difficulty walking, reduced distal proprioception, recent antibiotic therapy with history of lumbar puncture.
Well, yeah, maybe there's prominence of the subarachnoid spaces.
Okay,
seen
look at
around
the edge of the
cord.
film, please. Edge of the film.
Yeah, the edges of the film. The paraspinal soft tissues appear normal. I can see no definite lesions, collections.
Okay, no problem. As the patient underwent before lumbar puncture and there is decreased movement of the lower limb, we did lumbar MRI. You can scroll.
Right, so this is the lumbar spine MRI, T2 weighted sagittal images. Again, are seen in homogeneous bone marrow signal with increased hyperintensity to weighted signals in the lower lumbar and the sacral vertebrae. The distal cord appears slightly hyperintense in T2 weighted images, and there is what seems to be like clumped coda equina nerve roots giving a pseudocord sign.
Anything else?
Say again, please, sir.
Anything else?
Okay. Degenerative disc changes and herniations. There is some loculated collection or septations in the posterior epidural space around the distal cord and the lumbar thecal sac.
Any
Given
specific
the
feature in this collection?
it's inhomogeneous. It's not totally hyperintensity to the images. There are foci of hypointensity and isointense signals, signifying that there is some content or debris inside. So, given the history of recent lumbar puncture and collectively, I would suspect the presence of arachnoiditis in this case, and I would like to recommend reviewing of previous images as well as completing the scan with post-contrast images.
Here's the axial T1 post-contrast.
Right, so these are axial T1 fat-sat post-contrast images. I can see that there are clumped nerves in the coda equina, and there is also.
Can you show me the clump?
Yeah, it's this region, for example. These are the nerve roots in here, and some others are clumped in the posterior, and the enhancement here around is the epidural sac and the septations that we saw before. So the coda equina nerve roots are grouped all together in the thecal sac, and it's giving the pseudocord sign with enhancement of the dural sac and the septations and enhancement around the nerve roots themselves. So collectively, this confirms the preliminary diagnosis of arachnoiditis in this case, which could be a long-standing sense of the presence of some septations and. Yeah.
Okay. Can scroll.
Yes, again, this is the sagittal T1 fat-sat post-contrast. Again, are seeing the septations and loculations along the posterior aspect of the thecal sac and the epidural space. Also, again, are seeing the clumping and enhancement of the coda equina nerve roots anterior to the collections. Again, these are suggestive of long-standing arachnoiditis. My differential diagnosis in this case would be tuberculosis as well, and these can be loculations of TB. However, TB would be is less likely since it would be more likely to involve the subligamentous spread and the spare the discs and involve the end blades. So this is less likely, especially given the history of lumbar
How
puncture.
will you manage this case?
Yes, I would urgently phone the referring physician and recommend reviewing of the previous images and doing lumbar puncture again for aspiration of the contents and probably biopsy of the dural sac for culture and further analysis.
Okay, thank you.
Thank you, sir.
Here, patient did the cervical and dorsal spine, some degenerative changes, herniated discs like this, but along the edge of the fill, you will note there is epidural collection here. So MRI of the lumbar spine confirmed the presence of epidural collections here, and there is indentation on the cord, and there is abnormal signal intensity from the coda equine nerve roots. Okay. Some edema within the paraspinal muscles. And so we asked for, and here also. Oh, by the way, also here, you look at the collections, you will find air fluid level here, leveling, because the patient is lying down. So you will find some fluid levels here. Stair sequence. There is so much edema within the paraspinal muscles extending through the facet joint. We did also T2 collection here, compressing the coda equine nerve roots here also. So the pathology, if you saw here, coda equine nerve roots just compressed. On the sagittal T1 post contrast here, there is peripheral enhanced collections, same we saw. Okay, extending here and here and here also. I couldn't see, I think the cord, no significant abnormal, or maybe reaction enhancement, but it is not the main pathology. Main pathology is epidural collection with infection. There is here also abscesses here, paraspinal muscles, peripheral enhanced. So it was a case of spinal epidural abscesses, and the patient underwent drainage and treatment, and it become resolved totally. Okay. In my opinion, you go for arachnoiditis, but the main pathology is epidural. I don't know why. I think the epidural collection is evident. Why are you going for here arachnoiditis? You didn't convince me there is arachnoiditis really. Even here, it is the image is not so clear too, and here's the coda equina nerve roots. Not so much enhancement. I can see. I think, and they ignored the collection surrounding the core. This is common exam case, by the way. Okay. Thank you, candidate 11. Candidate 10, can you hear us?
Yes, I'm back. Yes.
Okay, we lost you on while
Yes.
we are discussing.
Yeah.
Okay,
Yes.
here is your case.
Thanks a lot, sir. Thanks a lot. This next chest frontal projection here, we see the lung fields are normal, the heart size is normal, ribs are normal. However, there is a lobulated soft tissue opacity is seen in the left supraclavicular region, and there's erosion as noted in the left scapula at the anterior aspect. So these findings suggest of aggressive lesion. involving the left scapula. This could be Ewing sarcoma. This could be osteomyelitis. I will do the further describe the finding. I will convey this finding to the referring doctor, and CT scan of the left shoulder should be done to see the
CT scan.
MRI of the left shoulder should be done to see the extent and soft tissue mass of the left scapula. And after
Okay,
this,
here's the MRI. You can ask for the control, or you have the control already.
yes, I've asked the control. I've asked the control, but it is not.
Okay, I think you can scroll. If I give you the control before or not?
No, it was not given before. No.
Okay, ask for the control, please.
Yes, requested.
Okay, approved.
Okay. Yes. Here I can, first of all, I've scrolled the images from top to bottom. Then I will be able to describe my findings. Here I'm going downward. So there is an area of altered MR signal is seen in the left scapula. And this is associated with the extraosseous soft tissue mass in the superior respect. So these findings likely represent neoplastic mass lesions such as osteosarcoma. I will immediately I will refer these findings to the regional center, sarcoma center, for further biopsy and management of this case. And CT scan chest should be done to see any metastatic disease in the lungs.
Okay. You did very well when you saw the abnormalities. Okay, I brought this case to accommodate ourselves for any soft tissue or abnormality here. If you look at the soft tissue here and there, if you will compare, you will find abnormal soft tissues. Then after you saw abnormal soft tissue, you have to look at the surrounding bone. You will find there is lytic lesion here involving the upper portion of the left scapula. You have to comment on the no any other bony lesion, no rib lesion, no bony, no other soft tissue lesion within the lung. The other side it appears normal. So if you found here bony, 10 years old, you have to ask for MRI. Okay, to be safe. MRI. What are you looking for in MRI for this patient? And what the protocol of MRI you will do?
Soft tissue mass and skip lesion.
Okay.
And extraosseous soft tissue mass, skip lesion, and extent of the bone involvement, area of altered MR signal in the bone.
Okay. Same. MRI will see other lesion, soft tissue component, extension of the lesion, involvement of the neurovascular bundle. Okay. Then we have to, unfortunately, they didn't do contrast for this patient, but the large soft tissue component. We have to look also for coronal sagittal views like this. Okay. And then you are suspecting malignant lesion or aggressive lesion. So I have to refer the patient to local sarcoma center, do CT chest and abdomen and bone scan for staging, and advise biopsy of this lesion under the guidance of orthopedic to avoid any seeding. Okay.
Okay.
And the patient, by the way, did CT. Okay, CT here, there is permeative lesion, soft tissue component, and they did removed the left scapula and he take chemotherapy. What is this line?
Portacath.
Is portacath. Okay. What is the? What about its location? Is it normal in position?
Yes, this is in the SVC line. This is in the SVC for the drugs for drug administration.
Okay. So this patient was Ewing sarcoma of the left scapula. Okay, thank you.
Thank you.
Now we have candidate 12. And 12. No candidate. Can 12? We can't hear you. Candidate 12, not there. Okay. Okay. Candidate 13. No, 13. Okay. 14.
Yes, doctor, I'm here.
Okay. It's good luck for you to reach. Okay. Go ahead. I will give you the history. Trauma, knee trauma.
Okay, this is
Simple case, but common exam case. Okay.
okay. So this is a lateral radiograph for the knee for trauma patient. First, I will check. First thing I can see there is suprapatellar effusion noted. I will check the cortices of the femur, patella, tibia, and fibula. I can't see obvious fracture. However, I can see that there is a deep sulcus sign noted within the lateral femoral condyle. This sign is indicative of ACL tear. In my routine practice, I would like to check also the other orthogonal view, which is a frontal radiograph, and to confirm.
What is the normal distance of?
Up to 1.5 millimeter.
Okay. So, what will you do next for this patient?
So for this patient, after checking the other orthogonal view, I will alert the referring clinician and advise further assessment by MRI to rule out ACL tear.
Okay, here is a MRI corner. You can ask for the remote control.
Yeah, okay. Yeah.
By the way, musculoskeletal trauma may come long case, may come in VIVA, like this. Okay.
Okay.
We are limited to shoulder and knee, no wrist, no ankle, like this.
Okay. So this is a coronal BD FATSAT coronal images for the knee. I will scroll through the images.
What are you assessing in coronal images?
In coronal images, first I will assess the menisci and assess for like bone marrow edema. Also assess the medial and lateral collateral ligaments.
Okay.
So I can see that there is.
Tell me, I am looking at this. I'm looking at this.
Yeah, I'm looking for first thing I can see that there is a contusion noted within the lateral femoral condyle, and I'm checking now I can see here that there is a abnormal signal noted within the intercondylar fossa of the of the femur, which I will assess also later in the sagittal cuts. I can see the horns of the menisci, the lateral meniscus, and the medial meniscus appear normal for me in this view. And this is the PCL. I think it's normal. So in this view, I can see the bone contusions suspected.
What about the medial collateral ligament and the lateral collateral ligament?
Yes, sorry. I forgot. Yeah, so here's the medial collateral ligament. I can see that there is it appear intact with high signal intensity noted surrounding it, which might be due to sprain. And the lateral collateral also it appear intact. The fibers are intact with high signal intersubstance, might be due to sprain. So now I would like to check the sagittal BD FATSAT.
Here is the system.
Yes, in the sagittal, I'm checking first. This is the lateral meniscus. The posterior horn and the anterior horn appear normal. While I'm scrolling, this is the suprapatellar.
What are you assessing in the sagittal?
The menisci. First the menisci from the lateral anterior horn, posterior horn. Then I'm assessing also the patella, the quadriceps tendon, and the patellar tendon. And I'm going centrally to check the PC. This is the PCL. It appear a little bit sagging. And ACL. Here I can see that there is a high signal noted within the ACL with I can't see continuation of the fibers here, which suggestive of ACL tear.
Conclusion?
And also check for posterior the muscles and if there's any Baker cyst or something like that. So there is a prepatellar also soft tissue edema. So this is a case of ACL tear with suprapatellar joint effusion. No acute bone injury. This is anterior cruciate ligament injury.
How will you manage this case?
This need urgent orthopedic review, as this patient might need surgical reconstruction of the ACL.
Okay, thank you. Well done.
Thank you.
This is a case, but common case in long and also may come in VIVA, but less likely. Okay.
Yes.